You are listening to the sound of a startling new kind of excitement. 4 men and a beautiful girl, off on a fantastic voyage, actually entering inside the human body, exploring an unknown universe, unknown dangers.
They're tightening. I can't breathe.
Have you heard of the movie Fantastic Voyage?
Yes, I've heard of it. I haven't seen it.
Do you know
though.
anything about it?
It's about a really fantastic voyage.
Fantastic Voyage is a 1966 science fiction movie about operatives who get shrunk down to the size of a microbe to be injected into the body of a scientist. It's crucial to the world that his life be saved. He has a blood clot, and they have 1 hour in a little spaceship to swim in his blood vessels and other, bodily fluids to beat this blood clot. I saw it when I was a kid. It was a fascinating movie. And it is, to me, illustrative a little bit of where we are today in terms of wellness.
Yeah.
eMove Think is through Medcan, and Medcan exists kind of at the intersection of stuff that sometimes seems science fiction, but is actually becoming reality. And so one of the things that Medcan has been looking into for a while now is liquid biopsy. Liquid biopsy is the notion that circulating in your bodily fluids, if you have cancer, are little bits of tumor, perhaps tumor genetic material, cancer genetic material, or
Cancerous cells.
Yeah, fragments of cancer. And the notion of liquid biopsy is taking a blood sample or a sample of another bodily fluid and then really taking a look at it for biomarkers that would indicate that you actually have cancer. This is pre-symptomatic, way earlier than you would ever be able to detect in the past.
I mean, with the frequency of cancer diagnoses these days, that would be a huge game changer in everyone's health and wellness. Like, we all know someone that's been affected by cancer, and that is an amazing stride. It seems like Fantastic Voyage is what Medcan might be embarking on.
It feels like it's science fiction. To me, it feels like science fiction. This is the type of testing that in the near future we anticipate being able to offer to Medcan clients.
That is huge and very exciting.
Super exciting. So we're going to explore it today. We're going to explore the state of the art in liquid biopsy. We're going to ask some questions.
So who are we asking these questions to?
Medcan's Director of Clinical Innovation, Allison Hazell, investigates with the help of...
With the help of Dr. Lewis Roberts. He's the director of the Mayo Clinic's Hepatobiliary Cancer Lab and an expert in liquid biopsy. Can we elaborate on hepatobiliary for a second?
Hepatobiliary, having to do with the liver plus the gallbladder, bile ducts, or bile.
Those are some pretty hard-hitting cancers.
Yes, and he's an expert in liquid biopsy.
Amazing.
In conversation with Dr. Lewis Roberts, here's Allison Hazell.
Nice to meet you, Dr. Roberts.
Hi, good morning.
We have a really fascinating show today about a potentially game-changing way to detect cancer earlier than we ever thought possible. Before we get to that, Dr. Roberts, can you provide us with a quick description of your work at the Mayo Clinic and provide us with a snapshot of your career in a nutshell?
Allison, it's a pleasure to meet with you. I'm a gastroenterologist and hepatologist at the Mayo Clinic. That means I study the guts and the liver. My particular interest is in liver cancers, and that includes cancers that are of the primary cells of the liver as well as of the bile duct cells that form within the liver and carry the bile to the intestines. My interest in research began as a medical student in Ghana, where I grew up. And because of my obvious interest in research, one of my professors really encouraged me to seek further training. So I ended up doing a PhD in physiology and biophysics at the University of Iowa in Iowa City. And while working there, I studied the regulation of gene expression in the liver. So that was my first introduction really to liver research. I subsequently moved to Mayo Clinic to complete my clinical training and then decided to focus my career on liver and biliary tract cancers. And my main interests there are in understanding the risk factors for these cancers, better understanding how these cancers form and how they spread in the body, trying to develop better tests for early detection of these cancers, and also trying to develop better treatments.
Incredible. There's been a lot of excitement and anticipation about liquid biopsy testing for cancer screening for many, many years now. And we actually first really understood the power of it through the association of a then emerging prenatal screening testing called non-invasive prenatal testing. Can you provide our listeners with a bit of background and history on the field of liquid biopsy screening?
So as you mentioned, some of the early indications about the value of non-invasive liquid biopsy testing came from prenatal testing. Some women would have test abnormalities that came not from their fetus, but instead that we were seeing abnormalities that were due to a cancer that had developed. And of course, typically it would be a rare instance, but cancer that had developed in the mother, where chromosomal abnormalities in the cancer were being detected. And so that led to potentially the case that we could develop tests that specifically looked for abnormalities that were associated with cancer in the blood of patients. The non-invasive prenatal screening for fetal abnormalities really helped to increase our appreciation about the value of doing this type of testing in cancer patients.
And so for our listeners, can you just in kind of the most basic level, I know it's a very complex technology, but just kind of give a general overview of what liquid biopsy testing is and how far or how similar or different is the technology being used today than was in that kind of NIPT, NIPS days?
So the current liquid biopsy testing, it really encompasses two different types of technologies. One is the idea of finding cells that have been shed from a tumor that are circulating in the blood, or what we call circulating tumor cells. And if we think about it, that's how tumors metastasize, because some cells leave the tumor and they go float in the blood. And if they find a home somewhere else where they can grow, then you have a metastasis of a tumor. And so if you have a technology that can take the cells in a sample of blood and sort them to identify those cells that are cancer cells compared to the normal cells, that's one way of detecting a cancer. The other technology, I think, has grown into more common use, really consists on being able to detect smaller fragments of cells. Sometimes it's little vesicles that bud off of a cell, but then float into the blood. Or as a cell grows in a cancer, we find that many cancers have high rates of cell growth, but they also have fairly high rates of cell death. So the contents of those cells also will spill out into the blood. Then we can detect different analytes that come from these cells that are breaking up in the tumor and have their contents floating up into the blood. We can detect the DNA, for example, that's inherited from these cells. And when we look at the inherited DNA, there's different types of things we can look for. Cancer, for example, we think of very much as a disease of where the genome of the cancer is disordered. You have abnormalities in the chromosomes, the very basic language of the cell, so what we call mutations, where instead of having a particular amino acid that's coded for, that's the normal amino acid, you might have in a particular protein a different amino acid. So the language of the cell in the genome changed, and that causes the wrong amino acid to be put there. And usually you have two things that can happen. You have an amino acid that makes a cell more likely to grow, so that you have what we call an oncogenic or cancer-causing mutation, or you have other proteins that normally put brakes on cell growth. And if you have a mutation in those proteins, that can reduce the brake on cell growth and sort of make the cell more likely to grow as well. So those we tend to think of as tumor suppressors. They stop growth of cells, but if you have abnormalities in the tumor suppressors, those can also cause increased cell growth. So you're looking potentially at DNA mutations that in some way increase the growth of cells. But in addition, we know that there are other mechanisms. Many of these we tend to think of as things that change in cells on top of what happens to the genome. So we call them epigenetic changes. And one of the most common of the epigenetic changes is a form of change that's called methylation,
Right.
where you get additional molecules added to the DNA in the cell. And these cause changes in the rate of expression of particular genes.
So just to clarify or kind of play back what I'm hearing, is it accurate to say primarily right now at this stage, the two main ways that liquid biopsy is being done is either through the detection of these kind of circulating tumor cells. We detect that through analyzing the DNA of that cell to identify it as a tumor cell versus a kind of healthy normal cell, or through methylation and measuring kind of the things that sit on top of that DNA and using that as a flag for a cancer cell. Is that accurate?
Yes, that's accurate. Those would be the two most common. And, there's some methods that also use mutations.
Okay. Do you foresee liquid biopsy in the future using multiple biomarkers or methods to screen? Or do you think it's primarily kind of, we'll find out over time one of these technologies or one of these approaches is much better than the others?
We tend to call cancer that forms in a certain part of the body the cancer of that part of the body. So we talk about breast cancer, we talk about cervix cancer, or prostate cancer, or liver cancer. But in actual fact, if you look at liver cancers, you're actually talking about many different types of cancers that happen to form in the liver.
Right.
And so the observation is that some of these cancers may be best characterized by abnormal methylation. Some of them might be best characterized by abnormal mutations. Some of them may be best characterized by abnormal proteins or glycoproteins. And so what we are learning is that if you wanted, for example, to find all the cancers in a particular tissue, or for that matter, in the whole body, you might have to combine different types of analytes to actually come up with the test that best detects all the possible different types of cancer.
Interesting. That makes a lot of sense. I think in terms of where liquid biopsy testing has kind of been used more in the past few years versus where I think we see it going, can you talk a little bit about kind of liquid biopsy for the monitoring of people who already have cancer versus this technology being used in kind of healthy people who aren't known to have cancer and trying to pick it up at an early stage?
Yes, that's a great distinction to make, because liquid biopsy can be really helpful if, for example, a person has a particular type of cancer. We're able to, let's say, remove that cancer from their body. But we know, as we discussed, that it's possible for cancer cells to spread even before the tumor is removed from the body. So you might want to check to see, is there any sign of recurrence? Is there any sign that the cells that had settled in different parts of the body, maybe even in the same organ, before the tissue was removed? And so you can actually analyze the tissue that you took out, the cancer, the tumor that you took out. And in some cases, you can actually design a test that is specific to that particular cancer. And then you could go back to the patient and apply that test periodically to see if there's any sign of that particular abnormality reappearing in the person's blood. As we've studied more and more cancers, though, and have the capability of having multiple tests in one larger test, so we can measure multiple abnormalities in one test, then we can actually take a whole panel of changes. And when a person has their tumor removed, if the person, for example, tested positive for a particular change in the panel, we can take blood samples periodically on that person and say, are we seeing a recurrence of this particular change? So in that case, we don't have to create a new test for every patient.
Mm-hmm.
We can use a test that broadly detects many of the abnormalities we see in cancer and apply it repeatedly.
In your practice, how common is that in people that you treat who have cancer, that you are doing this type of liquid biopsy testing for post-surgical monitoring or to monitor the efficacy of their treatment and that sort of thing? Is that still a pretty rare thing that you're doing, or are you seeing that become more common?
I would say it's still quite rare. I think that much of the time we are doing this as part of clinical studies at this point. For example, doing trials of patients who have particular abnormalities that are causing their cancer. we are treating them with drugs that target that particular cancer type. And then in terms of the follow-up screening, we're screening for those particular mutations. But I think that we're still seeing, a slow uptake. And I think in many cases, we are developing the evidence base for what would be the standard way to go about doing this for the cancers that we're now able to detect on a molecular or DNA-based level.
So then moving on from that, we are starting to see kind of emerging tests and offerings for people who are healthy and using liquid biopsy testing as a way to potentially screen for a high number of cancers that could be very early on. Can you talk a little bit about where that field is going in that direction and your experience with that so far?
Yes, and I think this is one of the most exciting parts of liquid biopsy testing is this whole idea of multi-cancer early detection. In my field, I study two different types of cancers. For example, one of them, primary liver cancer, is actually quite a common cancer. And in those people who are at risk for it, it occurs at a frequency that's high enough that we can identify a group of people that have chronic liver disease and say, these people definitely need to have testing every few months to see if they're developing a cancer in the liver. And it's easy to justify because we know the rate is relatively high of picking up the cancer. And the other type of cancer I study quite a bit is biliary tract cancer, or cancers of the bile ducts. Relatively uncommon compared to primary liver cancers. And so it would be very difficult in the average population to justify testing everyone for a cancer that's relatively uncommon. And I think that's where multi-cancer early detection really helps, because we can build within the same test subtests that will detect the most common cancers, and that justifies testing for everyone. But a great bonus along the way would be being able to detect the less common cancers like bile duct cancer.
That's actually a great way to lay it out and not a way I'd really thought about it before. In the example of the primary liver cancer, in the absence of liquid biopsy testing, what's the standard way that you screen high-risk people, and how good is that kind of standard screening?
Yeah, so the standard screening up till recently was using an ultrasound. So we're basically looking then for small spots that are occurring, but often we're looking for these spots to be occurring in a liver that is itself nodular. It's because the liver has scar tissue in it, and so it has lots of little nodules or like spots in it. And we're trying to look for new spots. So you can imagine that can be quite difficult. Mm-hmm. In addition, we have this increase in the general size of the population. And so with that, it's actually more difficult with an ultrasound to get a full view of the liver when you go to look at it. So that's something that we're facing at the same time when with obesity and what we call fatty liver disease, that is actually becoming one of the most common causes of liver disease that causes liver cancer. A couple of the technologies that have been developing recently are looking at a combination of proteins, and researchers have built models that include the sex of the patient or their gender, as well as their age. And so they actually build a mathematical model that helps to predict whether a person is at high risk of developing liver cancer. Alternatively, we have begun to develop methylation-based markers. So there are a number of companies that are working on methylation-based markers. And then we actually have a couple of products that are in the sort of early sort of pre-launch phases where they have a combination of the alpha fetoprotein with methylation-based markers together.
Interesting. So in terms of timing and utility of liquid biopsy screening, how much sooner could a liquid biopsy tell you somebody has cancer versus kind of a traditional imaging through ultrasound or MRI?
We have to do what we call a phase 3 study. And that's the idea, is that we take a group of people who are at risk of the cancer. We take a blood sample from them every 6 months or so. And over time, we follow this group to see who got a cancer. But we've stored all of these blood samples prospectively. Then we can take our new blood test and go back retrospectively and say, okay, these were samples that were collected on patients. This patient eventually developed a cancer at this point in time. How much earlier, before the time of cancer detection, was the test positive? And we are just now seeing some of those studies coming out and then telling us that, yes, indeed, sometimes we can detect these cancers 6 months, 12 months, 18 months, 24 months ahead of the clinical diagnosis of the cancer.
Interesting. And I imagine that probably differs based on cancer type or location of the cancer. We may see kind of the ability to detect it sooner in some cancer types versus others.
Absolutely. And even within a specific cancer, there may be subtypes of the cancer that are growing more aggressively than others. There's a cancer that's growing more aggressively, you might be able to detect it sooner than one that might be more indolent in its growth, for example.
Interesting. Are there any particular cancer types that liquid biopsy testing is looking like it's better suited for in terms of screening?
That's a great question. The sense I think I have is that for the major cancers that are being studied, liquid biopsy actually is pretty good at detecting most of the cancer types. You have more samples available of a more common cancer. You can more easily detect the different subtypes of the cancer. And if you have a cancer that is less common, that might take more time to figure out what are the best biomarkers. So I think in general, the sort of first generation of products that we are seeing are best for the most common cancers. But I suspect it's just a question of time.
In your practice, do you follow or do you see individuals who are known mutation carriers for kind of germline mutations? So I'm just thinking about this group of people who, have a known genetic mutation that we know puts them at a higher risk. Is liquid biopsy a test that's being considered for that group?
Yes, I would imagine that those individuals who are at higher cancer risk would be considered good candidates for multi-cancer early detection. Mm-hmm. And we do see some proportion of the patients with bile duct cancer, for example, have what we call mismatch repair deficiency. And so those individuals have lost the ability to more effectively repair their DNA. And so they're more likely to develop certain types of cancers. You would imagine that those individuals would be good candidates for the multi-cancer early detection test.
So let's talk about the state of the art in terms of today and what we can do with liquid biopsy testing. What are we able to do today? Kind of where is the evidence strongest? Is this still in a research phase, or is there a role for this in kind of clinical practice?
I think in some cancer types, we're actually at the point of being able to use liquid biopsy quite effectively. So I think particularly about a subtype of intrahepatic bile duct cancers. These are the cancers that form at the very edges of the liver that affect the bile ducts. And these are some of the cancers that are most likely to have specific mutations or alterations for which you can personalize treatment. The other thing we've recognized is that some of those patients, after treatment with a drug, will develop resistance. And you have the growth of new tumors that have made a new mutation that's resistant. So in that context, you can see how it makes a lot of sense to, first of all, test the patient to see what the particular aberration is that they have. It helps you select the drug that they're on. But then even while they're on the drug, it makes a lot of sense then to repeatedly do a liquid biopsy test.
Interesting. And so how does that relate to the commercial tests that are being offered now to healthy individuals? And I use the term healthy, obviously that's kind of a subjective term, but people who aren't known to have cancer already. Can the liquid biopsy pick up a cancer type and give you that amount of information so that you can kind of have a good sense of what type of bile duct cancer has been detected?
Great question. I think the liquid biopsies that we have currently for early cancer detection tend to be different from the ones that we use for characterizing the cancer that you've detected. The early cancer detection tests tell you, yes, there's evidence of a cancer here, and it's more likely in this location. And then these other liquid biopsy tests that we have, let's say the early cancer test said it's likely in the bile ducts. You would do a number of other tests. You would do imaging tests like an MRI or CT scan, but then you could come in with either a tissue biopsy or a liquid biopsy and say, okay, so we know we have a bile duct cancer here. What's the specific subtype of bile duct cancer? And for that, you would be doing a different type of liquid biopsy test to see if you could find the fusion or mutation that then can be specifically targeted with a specific treatment.
That makes sense. Have you been involved in cases where somebody has screened positive? So someone from kind of that healthy group has screened positive through one of these liquid biopsy tests and come to you then for follow-up?
I actually haven't at this point. I know that these tests are increasingly available, and there are a number of centers that are offering them. We actually participated in some of the studies in which patients provided samples for these tests, but I haven't started to see patients come in with a positive test.
I think in thinking about some of the cautions that experts have around liquid biopsy testing in healthy individuals, there's a lot of talk about not assuming this is going to be the magic bullet. There's a lot of talk around kind of the risk of false positives and the psychological and financial implications of somebody screening positive on one of these tests and going through a whole diagnostic odyssey and learning that it's actually a false positive. I'm wondering kind of how you think about these types of concerns in the context of your own clinical practice.
That's a great question. I think a very important question. And I think one of the key questions that the whole field of early cancer detection has to deal with going forward. One approach, and I think the sort of scientific approach, is to try to identify biomarkers that really have the highest specificity possible. That is, these are biomarkers that really reduce the rate that you might have a false positive test. Another approach might be to determine whether once you have a positive test, there's a specific algorithm that you go through where there are, in a sense, reflex tests that you do that are, in a sense, tests that help you follow up at relatively low cost and at low risk, but help you determine whether or not the initial screening test is positive. So you could imagine it being not just that immediately you have a positive test, you go to an expensive or an invasive procedure, but you go from the initial positive screening test to a confirmatory test, then on to the next test. And at some level, depending on the growth of the field, you can imagine that you could build your confirmatory test into your initial screening test. That's the point that we're at, is understanding what's the true performance of these tests and how do we best use these tests to inform our practices. So we think about a PSA, for example. We've had a lot of discussion about the value of PSA for prostate cancer screening. Any single PSA test has, a certain rate of false positives. Even when the test is positive and the person has prostate cancer, is it a less aggressive or a more aggressive type of prostate cancer that should be treated? But I think the goal of this new generation of tests is to help sort out these questions with non-invasive testing. And so I think it's very possible that what we will see is, as we gain more information about the performance of these tests, we'll figure out for which of the components of the test is it the case that if we see this component to be abnormal, for certain we have a cancer and we have to move forward. So I think there's a lot to learn yet about how best to use these tests to reduce, in a sense, the harm or the psychological harm from patients of having false positive results.
Yeah, I think that's a really good point. I think about it from kind of the genetic counselor lens. I do think a really important part of this type of testing or engaging in it is setting expectations up front and understanding that it's a screening test and not a diagnostic test, which I think having that level of understanding before you do this type of testing can be really important in terms of how you respond to the results. The point that you make about coupling kind of that tailored follow-up with this type of testing and having a plan for how you follow up based on what type of results get screened is a really interesting one.
Yes, I think it's really necessary when you think about early cancer detection that we all become used to the idea that this is a part of our lives. What it does from a population basis is it reduces the burden of cancer. It's one of the most important means of controlling cancer, reducing deaths from cancer. I think of it to be maybe akin to the fact that you get a cholesterol test every 5 years as an adult, something like that.
Mm-hmm.
Having a cholesterol test as part of your healthcare really helps in the long run to improve your life and reduce your risk of major illness and major complications.
Mm-hmm. It's like an added tool in your toolbox to give you information.
Exactly.
So where do you see the future of liquid biopsy in the next 1 to 2 years? No one ever wants to make predictions, but if you had to hazard a guess, do you see this field kind of growing significantly in the near term, or are we still a ways out?
I expect that it will grow. I think that as we see more uptake of liquid biopsy, we will learn better how to use it in the sense, as you mentioned, as a tool, both as patients and as physicians and in the healthcare system. We'll get a better sense of what are the best ways to use it. But I think that it really opens the door, not just for improved, less invasive diagnosis. And what we are finding is that one of the main barriers to people getting regular screening for cancer is the time it takes for them to, drop whatever they're doing, go in. If it's an imaging test, it takes a long time versus, driving into a blood draw center and having a blood draw, and it takes them 15 minutes, they're in and out. Just the ease of use of the multi-cancer early detection tests, I suspect, will help with compliance and allow us to be more able to detect cancers in more people at an earlier stage.
Amazing. Well, thank you so much, Dr. Roberts. I'm sure our listeners have learned a lot. We all know that cancer is a leading cause of death today, and hopefully one day soon, tools like liquid biopsy will get us closer to beating cancer, or at least minimizing its impact on the human population. So thank you so much for your time today, and have a great day.
You too. Thanks for the opportunity to talk to your listeners.
That was Medcan's Director of Clinical Innovation, Allison Hazell, in conversation with Dr. Lewis Roberts, Director of the Mayo Clinic's Hepatobiliary Cancer Laboratory in Minnesota.
We'll post episode highlights and links you can visit on our website, eatmovethinkpodcast.com.
Say hello and send us a tip or a suggestion by emailing us at info@eatmovethinkpodcast.com, and follow Medcan on Twitter and Instagram at MedcanLiveWell.
Eat Move Think is produced by Ghost Bureau. Jasmine Ratch is managing producer. Social media and strategy support is from Chantal Gertin and Andrew Imax, and executive producer is Christopher Scholge.
We'll be back soon with a new episode examining the latest in health and wellness.
This podcast is intended to provide general information about health and wellness only and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation or endorsement. The links provided within the associated document are to assist the reader with the specific information highlighted. Any third-party links are not endorsed by Medcan.